Greetings, everyone. My name is Amal Mattu, and I'm faculty here at University of Maryland, and welcome to our Crashing Patient Conference. For those of you that are interested in getting CME credit for the lectures that you're going to see, you can get CME credit on EMedHome. Check it out at www.EMedHome.com. And for those people that want live lectures, we're going to be right back here in October of 2013. Hope to see you then.
Good morning. I'm going to talk a little bit this morning about how to create a concise legal document, medical legal document that still conveys to the folks that might retrospectively review your chart what you did when you took care of your patient. Let's first start talking about how you get credit for what you did. There are three ways to do that. The first is the worst, and that's personal recollection. It's going to be yours and everyone else who actually laid hands on the patients. And remember that these cases may take place years after you've actually seen the patient. So these personal recollections diminish quickly over time. Often we can't remember what we did with the patient yesterday, not to mention 2 or 3 years from now. So that is one of the faults of this particular way of doing things. It's also influenced by outcome. The reason that we're all getting together to review the chart is because something went terribly wrong. So when there's a negative outcome, everyone's opinions on what they did and how they did it may differ than what actually took place. And because there's more than one person involved, there are going to be multiple versions of the same event. So this is by far the worst way to recall what actually happened to the patient. The other way to do it is personal habit or routine practice. This is very legitimate. It's a very good defense strategy in a very narrow window of scope of practice. It's a deliberate and repetitive action or practice that's consistent and generally reproducible under a given set of circumstances. For example, the way that we roll and clear a patient off a backboard. We've actually won a case recently where a doctor did not document what she did, but because it is so common in our practice, she was able to use as a successful defense strategy for how she removed a patient from the backboard. This is great in a very narrow window, but it's not going to work very well if you just forget to write something on the chart. So it's not going to work well under most circumstances. So that gets us to where we need to be, and that is direct entries in the medical record. Not only ours, but our colleagues, consultants, and also EMS records, transfer recordings, outside pharmacy records. All of these things paint a picture of what took place for the patient in and around the time that they saw you. So it's a good idea to take a look at as many of these records as is appropriate and make sure that what you are writing correlates with what you're finding in those documents. So what's the point of doing this? For the most part, we are trained to document very well for communication to each other. We document to communicate to doctors, to nurses, to consultants. That's it, period. We make lots of assumptions because we can. We read between the lines because we know what generally takes place, and we give our colleagues credit for what they do. Lay people are not able to do that, and lawyers are not willing to do that. So it's really important that you write down and take credit for what you actually did in the medical record. So really, what are we trying to do? Our records should capture communication and expectations set between the patients and the physician. It's almost a contract. It's a map. It's what I plan to do and the proof that I actually did what I set out to do. It should set a clear and complete clinical plan. It should communicate pertinent information and decisions, and that part we actually do fairly well. And it should give us credit for the competent care that we generally provide to our patients. If you do all of that, what you end up with is a nice tight chart that forms a nice legal defense in the unlikely case that there's some allegation of malpractice. So when do things go wrong? Nobody likes surprises, and problems arise when there's something that's unexpected. Sometimes the unexpected is only unexpected for the patient, but because we didn't communicate our expectations and what we thought was going to happen to the patient, it seems that it just suddenly came up, and the patients become upset with that. So if you have an unexpected outcome, if there's a delay in the clinical progress of a case, clinical decisions and dispositions are not clear, or they seem arbitrary. They seem to come out of thin air. And again, that almost never happens. It's just that to the patient, you haven't seen them in an hour, you walk in, you tell them something different than they expected, and to them it seems very arbitrary. If the chief complaints are not addressed, note that I did not say chief complaints are not all fixed, but you need to at least address them, okay? And with the follow-up instructions, when they're nebulous or impersonal, and you've seen this where we print out the 20 pages of documents for the exit writer in size 4 font. The nurse sticks it in a folder, hands it to the patient, and no one actually goes through that information with the patient. So they have no idea how to take care of themselves at home. Something comes up, and they see that as a complication. So we're going to talk very quickly about some general principles and then go through three cases very quickly to illustrate these points. And these things, if we follow them, give us a much more cohesive record. We want to eliminate the time gaps in the timeline for patients. We want to do a not-so-focused physical exam, which is a bit counterintuitive to how we're trained. We're going to talk about some non-clinical this and that, some things that you better have a good explanation for if they end up on your record. How nursing notes are your friends if you read them. Don't just stand there, do something different, and then how to discharge your patients with care. All right, very quickly. The first thing that any attorney does when they get a hold of a record is to create a timeline. They want to see when you did what, and if there's a huge gap in the timeline that can't be accounted for, that's when they're going to say things went wrong, because it's easy to blame things on you when there's nothing written down. So it's very, very important, and I know we're being beaten over the head with this, but it's important. Date and time, everything, or at least the attempt to get something done. You want to at least do your initial contact with the patient. That's the one that's left off most frequently. Significant events, decisions, and interventions. Attempts to contact consultants, particularly if it's repetitive. Delays in the progress of care. One that comes to mind is unable to draw bloods or get an IV in the patient to give medications. Arrangements for transfer, and decisions for the disposition of the patient. Make sure that you time it when you did it and not when you write it. Often we do things at 7 o'clock, but we don't have time to sit down and write about it till 7:30. Well, you can take credit for thinking about it and doing it at 7. Make sure it's documented as such. And please correlate your timeline with the nursing timeline. You need to make sure that it looks like you were taking care of the same patient and not that you have two completely different timelines that don't jive and don't make sense. The not-so-focused exam. This is a bit counterintuitive to how we were trained. We are very proud of the fact that we can go into the room and in 5 minutes get the history, get the scoop, figure out what's wrong with the patient, do a limited exam, and move on. That's not always going to serve you well. I really recommend that you expand your differential a little bit and make sure that your interview, exam, and documentation is based on that true differential. It doesn't need to be a huge fourth-year medical student exam. We don't have time for that, and the patient doesn't really want that. But you do need to make sure that if someone comes in with back pain, and we're going to look at a case like this, patient comes in with back pain, and you think it's musculoskeletal, take 5 extra minutes and do a quick neurological exam and make sure that that can be documented appropriately. You want to avoid erroneous diagnostic momentum, and this is actually a term that I have borrowed from a colleague, but I love this term because it's what we do all the time. We hone onto a diagnosis, we put our blinders on, and when the red flags start flying through the rest of the progress of this case, we're so focused on that diagnosis that we initially thought of that we ignore these red flags and we don't look for other things. So you want to use an expanded exam and interview to negate your less common diagnosis, but at least it's on the chart. Doesn't mean you have to be right, but if you turn out to be wrong, at least you have some substantial evidence for what your thinking was when you were going through this case. Non-clinical this and that, very quickly, please avoid nebulous qualifiers on your chart. They don't mean anything. I have seen more than one doc sitting in a witness chair, squirming during deposition, trying to describe to an attorney what a toxic or well-appearing patient looks like. It doesn't mean anything. What you want to do instead is to use very objective observations. For instance, the patient notes decreased pain. It's now 0 out of 10. He took 200 cc's of PO fluids without recurrence of nausea and vomiting. He's ambulating without assistance. He's stable. He has normal speech and judgment. Child is laughing, playful, running around the room and climbing on the exam table. Patient's alert and oriented, answers questions appropriately, and follows commands. The patient's pain is worsening. It's now 5 out of 10 and unrelieved with Percocet. These things can be followed quantitatively over the course of the patient's stay. They're much less nebulous than things that can't be described easily or are not reproducible, or that different people may paint a different picture of if they write it that way. Things you better have a good explanation for. Anything, any symptom or sign that's new, worsening, or lingering needs to be explained. See it all the time on charts. I've seen it in several cases that can't, why is this pain unexplained? Why is it getting worse? Why is it still there? So the things that we see most commonly are pain, paresthesias and weakness, gait disturbance, nausea and vomiting, alterations on the level of consciousness, or even subtle signs in decreased mentation and abnormal vital signs. If those are there, they're new, they're worse, or they just won't go away, you don't necessarily need to fix them. There may be a good explanation for it, but you need to put that explanation on the chart, and it should make sense. Let me introduce you to your nursing note. I think at least half of us don't ever look at the note, particularly in our patients that aren't that sick. We're going to give a case where that turns out to be a bad idea. But please, for the love of God, read your nursing note. It'll hang you in the end if you don't. They do an excellent, excellent job of creating timeline, and often the lawyers are pulling the timeline not from our documentation but from the nursing note. So make sure that you are looking at it and that it makes sense with what you're writing on your chart. Check in frequently with your nurse. And I don't just mean, hey, how are you doing? But how is the patient doing? What's going on? How is the family? Is there anything that I need to know about the patient as I'm going through the course of the patient's care? Share your expectation and plan. That clinical map that we're writing with this chart should be shared with the nurse. She should know what we're trying to do so that her goals and your goals are the same goals by the time the patient is ready to go. And then just before that patient leaves, put your head together with the nurse and say, hey, I'm going to send this patient home. What do you think? Patient stable, family okay, patient good to go home. Oftentimes, because they are in that room 100 times to our one time, they see things we don't, they know things we don't, they have interactions with the patient and the family that we don't. So it's really important that you get their view on things and take it seriously. Don't just stand there, do something different. Again, we get into difficulty when we come to a halt in the care of the patient. There's a delay for legitimate reasons, but we don't document it, and we don't try to do anything else different. So if there is a delay in transfer, consultation, any kind of clinical intervention that you're trying to do, or getting a diagnostic test, or getting a disposition to a particular level of care for a patient, if the first thing doesn't work, try something else. Go to Plan B, Plan C, and even Plan D if it means that you're going to be able to get the care that your patient needs. You cannot just write a single note on the chart that you're trying to get a test and not anything else being done for the patient during that time. And then lastly, discharge our patient with care. The main thing that we don't do here is communicate our expectations to the patient. Oftentimes patients go home and what is happening to them is the normal progression of the disease. It's going to get worse before it gets better, but we don't tell them that. So what we see is a normal sequela of the disease process. To them seems like a complication because we haven't shared with them what the expectations are. So tell them what the limitations are of what we can and cannot do and treat in the emergency department. Give them a time frame and scope of recovery. It's going to take you 2 weeks to get better, and this is what better actually looks like. It may not be perfect. It may not be what you were pre-injury or pre-condition, but this is what it's going to look like. Make sure that you outline what the patient's job is when they leave here. They have responsibilities too. You've got to take your medicine. You said you're going to follow up with a doctor. It's important that you do that. Make sure they understand what their job is when they leave. And then, of course, you're going to give them precautions for return. And those are generally taken care of for us on those pre-printed records that were given out. For the most part, we do ensure our patients are stable from this, vital signs and that kind of thing before they leave. But sometimes being stable to go home also means that you're mentating normally, and we've documented that you can walk straight and that you can walk without falling over, and that you have capacity to be discharged safely. Generally, when there's a discrepancy here, we find it in the nursing note. Again, referring back to the nursing note. So you need to make sure that your patient is not only medically stable, but actually can take care of themselves and do all that stuff you ask them to do when they leave. Make sure that you have addressed or confronted all the patient's expectations. Again, note that I have not said that you have met every expectation, but that you address them, okay? I am a big fan of the new trend in creating a summary document to go with the 20-page packet that you're sending home with the patient that just has 5 bullet points. Here are the 3 things I want you to do. Ice, elevate, take your antibiotics. Here are the things that will make you come back, fever, or if the pain gets worse. And you said you were going to follow up with your doctor, and you promised to take your antibiotics. So you're going to outline their responsibilities when they go. You do, 5 bullet points on 1 piece of paper on the top of this other information. If they don't read anything else, they still get the gist of what it is that you want them to do. It takes a few minutes, easy to do, and can solve a lot of problems. All right. That said, we're going to launch into a couple of cases, 3 cases actually, that will illustrate some of the points that we just discussed and why they're important. The first case is a 48-year-old male that comes into the ER at 2:01 and presents with 10 out of 10 pain and spasm in the right upper back for the last couple of days. Has no history of trauma. Went to the gym and saw a trainer, got a little bit of relief with some heat and a nerve stimulator that they placed at the gym. Worked well enough, but the next day went to see his primary doctor, which was yesterday, and the doctor prescribed some pain medication. Didn't work real well, so the patient comes in to see you. He tells the triage nurse that he's had a brief fever a couple of days ago. It was subjective, felt warm, felt flush, got a little diaphoretic, went away, and hasn't had any since. He's got no significant past medical history except for a distant history of MRSA. It was a cellulitis of the face that did require hospitalization, but resolved spontaneously about a year ago, and the patient's had no similar issues since. At 4:09, the doc goes in the room. The vital signs are, as you see there, a very minimal bump in the blood pressure and temp of 99. Everything else is fine. This was documented on a T-sheet, so everything that you see is basically lifted directly from the T-sheet in a checkbox or backslash form. Anything in parentheses was actually handwritten in by the physician. So on the neck and back exam of significance, the patient did have a decreased range of motion, and spasm and mild tenderness was noted with X's on the schematic drawing over the left scapular region. And it was handwritten in that the patient had reproducible pain on arm abduction or rotation. He had a relatively normal neuroexam, but it was brief in how it was documented. He was alert and oriented ×3 with cranial nerves normal. And then a little bit confusing, it said under musculoskeletal that it was non-tender and full range of motion, which was a little contradictory to what was said in the neck and back exam. The nursing note was pretty brief. It just said that he got a nonsteroidal that was prescribed and administered around 4:18, and that half an hour later his pain was down from a 10 to a 2. He got discharge instructions and verbalized understanding of those discharge instructions. The discharge portion of the physician note at 4:20 noted that he was going to follow up with his primary doctor. His diagnosis was pain, acute in the upper back, condition improved, disposition was discharge on Motrin, Flexeril, and Percocet. And he got some pre-printed instructions for back pain with precautions for return. Sounds pretty standard. This was an urgent care patient. We probably see 10 a day just like it. So what happened? Why are we talking about this case? This was an extremely unfortunate case. Patient came back later the same day with a bilateral lower extremity paralysis and the beginnings of an upper extremity paralysis on one side. He did get an MRI and had a diagnosis of an epidural abscess. The patient was transferred to a tertiary care facility for definitive care, but unfortunately remains a quadriplegic, and this case is currently in litigation with a very high dollar figure attached to it. Again, when I talk about these cases, I'm not referring necessarily to the clinical care. I think the patient got appropriate clinical care during this case. Let's talk about what was missing from the documentation of the chart. The patient came in complaining of back pain. This is one of those cases of a not-so-focused exam that I was talking about. He had a very limited back and neuro exam. It was very focused on the scapular pain. The region was not in the midline, so there was no actual spinal exam. The neck and back was noted as, if you recall, decreased range of motion with spasm and mild tenderness over the left scapular region. The neuro exam was very, very limited, alert and oriented ×3 with cranial nerves normal as tested. So again, a few extra minutes to do a neurological exam. I think in this case the neurological exam would have been normal, but that would have been a helpful thing to have documented that this patient had a normal neuro exam. We make the assumption that he walked in and walked out because that's how he got to the ER. He didn't come by ambo, but the gate was not noted on the medical record. There was also in the litigation claim some claim made that the subjective fever was not addressed and the history of MRSA was not addressed. Not sure those are as clinically significant, but particularly the fever, a one-liner on why the guy had a fever a couple of days ago and had a temp of 99.2 in the ER would have been helpful. Okay. Case presentation 2. Timeline here is particularly important. This patient came in at 3:48 a.m. The 41-year-old male presents with his mother, who gives most of the history to the triage nurse and says that her son has been acting very bizarrely over the past couple of weeks, talking out of his head, not sleeping or eating, just kind of wandering the house at night and talking to himself. And yesterday he said that God wanted him to die, in quotes, and that he threatened to kill himself by hanging. This patient had no prior history of psychiatric illness. A couple of hours pass. The physician sees the patient and says, the patient says to him, "I'm fine. I don't know what all the fuss is about. My mom is the one with the issues. She lives with me. She's the one who's agitated. I do have insomnia, but it's because I'm stressed at work. That's it. I'm not homicidal, not suicidal, not seeing things. I'm fine." The doc notes that he's in no apparent distress. He's alert and oriented ×3. He does appear anxious, according to the physician, but the remainder of the physical exam and labs are all normal. The crisis evaluator, who is the psychiatric liaison, comes in and sees the patient, but there is no discrete consultation left on the chart. He writes patient contracts for safety and will seek outpatient care. and there's a signature but no time on that particular note. Okay, so that all sounds fine and good. Patient seems to be doing well. The nurse, however, documents just before the physician goes in to see the patient that the patient is agitated and restless. He appears to be talking to himself. He's able to be redirected with verbal cues, however. At 5:18, the patient remains agitated with suicidal ideation, evaluated by the physician, awaiting disposition. 6:05, patient is singing to himself. He's very agitated. He's pacing in the room, continues to express suicidal ideation. Medication for agitation is requested for the patient. And by the way, that medication was not given. At 8:11, the patient is seen and cleared for discharge by the crisis evaluator, and here is the nail in the coffin. This RN expressed continued concern over patient behavior at the time of discharge. Love it. So the patient at 8:15 was discharged in the care of the mom, who said that she would keep an eye on him until he could get to the new psychiatry appointment that they had made for him and the primary medical doctor in the next few days. He was diagnosed with insomnia, condition was stable and improved, and he got pre-printed instructions for insomnia. So what happened with this case? Patient continued to display very bizarre behavior throughout the community. He was actually had interactions with the police a couple of times in the community over the next couple of days. Ultimately, at the end of the next 24-hour period, was found in the middle of the night in a neighbor's kitchen with a knife. She obviously called the police. The police arrived on the scene. He continued to confront the police, lunged at a police officer, and was shot and killed by that police officer. And this case is now in litigation. So it's almost as though this nurse, this physician, and this crisis evaluator were seeing two completely different people. The physician noted that he never looked at the nursing note, and he denies that he was ever approached by the nurse to discuss her concerns about the patient's agitation. Complete breakdown in communication. There was a lengthy time from the time the patient arrived and had those first statements by the mother to the time that the physician actually saw the patient. He also never spoke to the patient's mother. Okay? The conflicting clinical documentation is just kind of unparalleled in this particular case. There was also no official chart, consult left on the chart by the crisis evaluator, who really represents the psychiatrist, and there was no communication between the ER physician directly with the psychiatrist, and clearly no coordination between this team of clinicians taking care of this patient. So this is clearly one that falls into talk to your nurse. Talk to your nurse, read those nursing documentations. It's not so much that you might even change what you do, but you want to make sure that you account for what she says so that you can at least write a note saying, you know, I hear what she's saying over here, but this is what I see and this is why I'm doing what I'm doing. I think in this particular case, if the physician had seen this nursing documentation, something different might have happened for that particular patient. And lastly, we have case 3. Timeline in this one's also very important. Patient presented at 12:27 in the afternoon. She was a 54-year-old obese female with a history of diabetes and gastroparesis. Comes in with a 3-day history of crampy abdominal pain and perirectal pain. She's nauseated, but she's not vomiting. She says she feels full and bloated. She's not been able to eat in the last couple of days because of her pain and nausea. She's got painful bowel movements with hard stools, and she's got some urinary frequency, but is not complaining of dysuria. The physician sees the patient about 3 hours later, 3 o'clock, and her vital signs are as follows there. Blood pressure a little bit up. The temperature is also a little bit up. She's got a finger stick of 605. It's noted that she's in no apparent distress, but she's obese. On exam of her abdomen, it's noted that she's got diffuse mild tenderness, no rebound, no guarding. There's some rectal tenderness. No hemorrhoids were noted. She's got heme-negative secretions, but of significance is handwritten in that the perineum is dusky and tender. Her labs come back with a glucose of 705, large acetone, a lactate of 5.2, and a white blood cell count near 29. So the CT is ordered about 45 minutes later, but it's noted that the patient is obese. She's over the 400-pound limit for the CAT scan machine in the facility that she's currently in. So arrangements were made. It's noted in the nursing note at around 5 o'clock that a transport team is going to be unable to pick up the patient until after 8:30. It's 5 o'clock, okay? As it turns out, the patient is transported to the tertiary care hospital at 11:22 to get a CAT scan. At that point, it's documented that her vital signs have taken a turn. Her pulse is up, her temperature's up, her pressure is down. So things are not going well for this patient. So what happened? The patient is transported to the tertiary care hospital. She gets the CAT scan. It's red, but they ship her back, and the phone call is made to the ER physician at around 2:12 that shows extensive necrotizing fasciitis in the pelvis. Patient is back at the initial hospital, continues to clinically decompensate, is taken to the OR at that facility where she has extensive debridement of the pelvis, basically a pelvic excavation, and then goes on to have multiple operative and post-operative complications, has ongoing genitourinary issues, and this case is currently in litigation. So what's missing? This is a case of do something different, very, very clearly. This patient was in the ER for almost 12 hours. She bounced to the appropriate level of care, and instead of keeping her there, they shipped her back. She actually should have probably stayed where she was to get care. We didn't even have vital signs during the period that she was away from the primary hospital. She had a long delay in transporting for diagnostic care, a long delay in obtaining definitive care, and of significance, there were no alternatives. If you have one facility that says we can't get to you until 8 o'clock, then call another ambulance service, call another hospital, do something, or at least document that you are trying. If a CAT scan is not obtainable, then is there another diagnostic modality that will work? Maybe not in this particular patient, but in other patients, it may be that an MRI might work, or that she can get an ultrasound at your facility. Patient was not started on antibiotics until after the diagnosis came back. So she went a huge period of time, even with a high sugar, a mild fever, and a perineum that looked dusky with no antibiotics. It's not going to hurt her. Why not get those started? And then there was also delay in calling a surgeon. If you can't get the CAT scan right away, get a consultant to come in, and maybe they can give you, there's some value to their interpretation of what needs to happen. So this was a case of do something different, try something different, have multiple things listed on your chart that show that you were trying to care for the patient to the best of your ability. So, in summary, you need to think of your chart as the story of the patient's experience while in your care. It should be very reflective of all of the elements that we've discussed and the elements that you have taken care of. And usually we do it, we just don't write it down, okay? So you need to make sure that it's reflective of your clinical planning, your decisions, and your interventions. Any progression or delay in the treatment of the patient need to be documented. Please document that you've communicated with your team members. And sometimes that's just a quick one-liner, that the vital signs are stable. It means that you looked at them, and that's appropriate. Justification of the disposition of the patient, and very important, the patient's responsibilities if you're going to be discharging them out of the hospital. So take your time. Make sure that these elements are there. It actually doesn't add that much time to the overall length of how long it takes you to take care of the patient, but if this case should end up in litigation, gives your legal defense team a footing to stand on to assist you in getting through those allegations. So go out there and document safely. Thanks a lot.